This is Dr. Paul Kanev discussing arachnoid cysts with you today. I'm the Senior Pediatric Neurosurgeon at Children's Hospital of Philadelphia. Arachnoid cysts are very common intracranial mass lesions, estimated to occur in at least 2 to 3% of children. These cysts are benign congenital fluid collections within the spinal fluid cisterns and major cerebral fissures. Cyst walls are thickened arachnoid membrane that border the adjacent cisterns, where the wall is tightly adherent to normal cerebral arteries, veins, and cranial nerves. The most common cyst location is the sylvian fissure within the middle cranial fossa. At all ages, left cysts are more common than right, and there's a 3-to-2 male to female predominance. In the lower left, we see a class 2 arachnoid cyst on this axial T2 sequence MRI. Class 2 cyst expands the middle fossa. It deforms the wing of the sphenoid and pushes the temporal lobe back. By the time the cyst is class 3, the insula is exposed and open. There's wide separation of the sylvian fissure and displacement of the frontal, temporal, and parieto-opercular cortex. In many cases, there's also midline shift to the opposite hemisphere. Less common supratentorial arachnoid cyst locations include cysts that are suprasellar in origin. This T2 axial and sagittal scan shows a large suprasellar cyst deforming the alignment of the midbrain and lifting up the floor of the third ventricle, causing obstructive hydrocephalus. These MRI of a posterior frontal hemispheric arachnoid cyst show the magnitude of the deformity of the cortex, and in this patient he also had seizures. In this MRI scan coronal, we see the deformity of the cortex, a slight effacement of the ventricle, and communication to the sylvian fissure. Less than 5% of arachnoid cysts occur within the posterior fossa. In this location, the most common sites are retrocerebellar with hemispheric deformity, with or without compression of the fourth ventricle, and hydrocephalus. This MRI scan T2 axial shows a moderate-sized cerebellopontine angle cyst with hemispheric deformity and compression against the side of the medulla. In nearly all cases of asymptomatic cysts and those found on incidental scans, non-operative management is recommended. In many cases, serial neuroimaging is appropriate to confirm static cyst size. Only about 1% of all cysts will change on follow-up studies. Surgical treatment is recommended in less than 5% of cases. Uniformly, children of any age who require surgery have focal neurological signs or symptoms, severe headache, progressive head enlargement, increasing bone deformity, or perhaps epilepsy linked to the location of the cyst. The goal of surgical management is reduction of the cyst pressure exerted upon adjacent brain structures. Regardless of location, the techniques for cyst surgery management include cyst shunting to the peritoneal cavity, craniotomy and cyst fenestration through open or endoscopic fenestration into the ventricles or subarachnoid space. Here we see a large hemispheric cyst in a very young child where a shunt catheter was inserted, avoiding going through the cortex. The catheter tip was localized in its trajectory by ultrasound. This is a view of an open craniotomy, which we'll look at in more detail in a future slide. And here's a view endoscopically of a middle fossa cyst with fenestrations made through Bugbee wire cautery. Historically, craniotomy offers the best success for microsurgical division of cyst septations and fenestration of cyst walls into the adjacent cisterns or ventricles and equilibration of pressure across cyst membranes. It's common that there are dense adhesions and adherence of the cyst wall to adjacent cortical and vascular structures, and these fenestrations are best made with bimanual microsurgical technique. Stereotaxic localization or ultrasound allows for small incision and craniotomy windows, and as the cyst is widely displacing adjacent cortex, Brain retraction is rarely needed. We frequently use dural reconstruction with graft and/or fibrin split glue augmentation because of the very thin dura from the underlying cyst. The advantage of cyst peritoneal shunt placement is the relative simplicity of the procedure and the low morbidity associated with fluid diversion. Disadvantages of cyst shunting include the well-known complications of shunts, including infection, overdrainage with hindbrain herniation, repetitive shunt failure approaching 50%, and intracranial hypotension. Shunts may be an endoscopic or craniotomy secondary procedure, or they may be the primary procedure for cyst management. This is an operative view of a left craniotomy for cyst fenestration. Here's one opening made between the carotid artery and the third nerve. And then we reoriented the scope, opening these dense cyst wall membranes both above and below the third nerve. Sometimes the cyst wall can be opened with blunt dissection. Other times it's lifted, microsurgically manipulated, and opened with sharp microsurgical dissection. The more wide open the fenestrations are, the more reliable the communication is, and the less potential for closure and failure of the operation. Endoscopic fenestration into the subarachnoid spaces offers all the advantages of minimally invasive surgery, including small incision and burr hole. We recommend registration of the endoscope tip to provide optimum trajectory guidance towards the medial membranes. With sylvian cysts, as we saw in the previous slide, the inner membranes enveloping the third nerve may be quite thickened, and without bimanual control, it may be challenging to fenestrate the cyst into the suprasellar cistern. Too much mechanical pressure during fenestration with either the scope, forceps, or Bugbee wire may contribute to postoperative ptosis. If this occurs, it's common to resolve completely within 3 to 6 weeks. CP angle cysts are best approached with retrosigmoid craniotomy, allowing bimanual microsurgical resection of the cyst wall and fenestration into the lateral pontomedullary cisterns along the path of the lower cranial nerves. This may be accomplished also with endoscope. We find that adjacent to the cranial nerves of the 7th and 8th nerve complex, the Bugbee wire fenestration and balloon dilation of the membranes must be completed with great caution to avoid postoperative facial weakness. With the increasing availability of CT and MRI, arachnoid cysts are diagnosed with increasing frequency. Nearly all collections are asymptomatic and should be managed conservatively with observation. Many patients are concerned about the relationship between cyst and the potential for greater trauma and subdural hemorrhage, although there are many case reports linking cysts with subdurals in activities including wrestling and roller coaster rides. The data does not support any restrictions or limitations upon activity. Patients with symptomatic cysts causing significant headaches or focal signs are candidates for drainage, whether that be shunting, craniotomy, or endoscopic fenestration. With the refinements in endoscopic optics and image guidance, minimally invasive surgery may be the preferred management for decompression. Long-term follow-up and serial imaging studies are necessary in patients of all ages. Thank you very much.